Okay, opiate addiction treatment. The word is in parentheses because, as I'm going to get into, there really isn't a clear definition of what treatment is for opiate addiction. And outside of medication-assisted therapy, there's really no medically validated method of treating opiate addiction. And the use of this continual use of this word treatment, it's a dangerous myth, and it's costing lives as far as I'm concerned, and it's costing a lot of people their livelihood, their money. I'm going to go into some of the reasons why I feel that way. What is treatment? I'm going to put the word in parentheses again because I want people to start thinking about it. It's all you ever hear with respect to addiction. Well, if they could just get treatments, or we need to have more treatments, we need to get the treatment available to more people. There needs to be more money towards treatment. Well, what does that mean? What does treatment really mean? I mean, you can think of it as a definition that it's a validated action or a medication that measurably improves illness or an injury. Would be a treatment. Like setting a broken bone with a cast is a treatment for a broken bone. Antibiotics for a bacterial infection is a accepted treatment. You can measure the improvement. You can see, improve, and quantify the improvement. Uh, to be scientific, it should always be measurable. You should be able to quantify it. But what do you measure? And here, I feel like people play loose with the terms. For a drug to be approved as a treatment, the FDA requires the drug to be safe and effective. It has to be safe and effective. But what does that particularly mean? Safe just refers to, it's rather self-explanatory. There's scientific and statistical definitions of what makes something safe, but basically you're looking at it doesn't adversely affect health and cause, unacceptable side effects, and you can statistically demonstrate through math after random controlled studies in a large enough population that a drug is safe. The word effective, though, is a little bit difficult. And here's where we get into problems with addiction, because a lot of these studies are conducted by social scientists. And I'm not trying to pick on them, and I do call it real science. Real science has a lot more stringent and strict definitions, and the math and the correlation coefficients are a totally different ballgame as opposed to the social sciences. And you see a lot of this causing problems right now with a lot of the studies regarding treatment for drug addiction. You see a lot of poorly defined words and poorly defined mathematics, and we'll get into that a little bit later in this. What makes it effective? What makes something effective? Well, basically that it's better than doing nothing, so that, you know, by taking this action, you will beneficially affect the outcome. And maybe only by a tiny, tiny, minute value, just as long as it's measurable, it can be judged effective, even if it's 1%. It's effective if it's better than doing nothing, if the intervention leads to a better outcome. Uh, you know, the size of the benefit can be great or small, but as long as it's measurable and there, you can get away with calling the treatments effective. And, as an example, antibiotics versus antidepressants. Both are accepted treatments for their, antibiotics are accepted treatments for infections. Antidepressants are accepted as a treatment for depression. But they're different. Again, antibiotics are almost always effective as long as it's a established, well-known infection. Things like strep infections. Antibiotics almost always work, and we can quantify that, and we can actually see it under a microscope. We can see that bacteria are dying, and we know that it works. But when it comes to SSRIs, depressants, the serotonin reuptake inhibitors, research and even the studies that were used to get the drug approved by the drug companies that put them out, you'd see that it's only a few percentage points higher than placebo. Uh, we're doing nothing in treating depression. However, since it's a small, tiny, minuscule improvement, a couple of percentage points above placebo, but it is measurable and it is statistically significant. So you can get away with calling SSRIs an effective treatment for antidepressants, even though if you push anyone familiar with the research, they will tell you that they're not all that effective. They lead to a very small improvement statistically over a wide swath of people. So both of these antibiotics and antidepressants are effective. Um, Based on the reliability of the quantifiable measurements. So they're both effective, but there's a big difference in how effective they are. And I'm just pointing that out because I want people to realize that the terminology can be played with to sort of sell what you're trying to push forward. And you'll see this with a lot of companies that are offering rehabilitation services for drug addiction now. They're saying that their treatments are evidence based, and we'll get into how that's not really true a little bit later on. So as I was just saying, the way you measure effectiveness counts. And with addiction treatments, how do you measure how do you measuring how effective it is? Are you looking at the relapse rate, or a lot of times you're looking at the percentage of people that complete the program, as if that has anything to do with the effectiveness of the treatment in and of itself. Do you look at relapse rates at 1 year or 5 years or 10 years? You look at failed drug tests, how many people are failing drug tests, self-reported wellness, or are you looking at recidivism in the criminal justice system? What are you using to measure effectiveness? Because if you use a lot of these proxy measurements, you can kind of draw a picture that's not really true. See this with a lot of the studies that are coming out, in the field, especially the ones that rehab facilities like to point to justify their enormous costs. They all start with its erroneous premise that there is a treatment, and I will get into later how there really isn't a treatment for opiate addiction other than medication assisted therapy. Those are the buprenorphine and methadone are the only two treatments that have shown to effectively have a quantifiable benefit for addicts. And I'm going to show you later how it matters not if the person is receiving counseling while they take those drugs. It's the drugs themselves that make the benefit. They always draw a conclusion of effectiveness based on, like I said, these proxy measurements, like adherence to the program or the times you return to rehab. But they're never really looking at, truthful, factual evidence of abstinence over a long period of time, and they never like I said, they automatically assume that there's a treatment and that it is effective. When they do these studies, it's you'll see how they play loose with the language. Um, so let me give you an example. Actually, I'm going to go to a website here with an example of one of these studies, and you see here this is a study that was published in a reputable journal, and it's asking if residential treatment is effective for opioid use disorder, the longitudinal comparison. They come down and they draw a conclusion here. The finding suggests residential treatment may be helpful for emerging adults with opioid dependence. So they're drawing a positive conclusion that residential inpatient treatment, which is controversial, and it should be, they're drawing a conclusion here that it may, and they always use these words, may be beneficial. Uh, so they're coming up with a conclusion that it may have some, may be warranted. But how do they come up with that conclusion? They do a study, and I don't want to get too deep into this and bore everybody, so I'll go down to just the results. We go down to changes during treatment. So this is what they're basing this off of. And so we see that they're looking at commitment to sobriety. Again, this is if you go down here, you'll see they measure that by doing a test. They give them basically a questionnaire, and they measure their commitment to sobriety before and after however many days in residential treatment. And look, more committed to sobriety after they've ended the treatment than before. So that must be positive. Self-efficacy. Again, that's just a questionnaire. Self-efficacy, abstinence, self-efficacy. It's gone up a little bit. That must be good. Coping skills. You give them another, questionnaire. Relapse coping skills. So, they've developed some level of coping skills. These are scored probably on the test. So they're scored from, they take the test when they come in, and then after they finish treatment, they take the test again, and lo and behold, they score a little higher on the coping skills test. And then here, this one's interesting. Intentions to attend a 12-step meeting. So, a 12-step expectancy questionnaire. So again, they assume that 12-step meetings are effective for opioid addiction. They just assume that. And then they say, well, hey, if you're more apt to want to go to a 12-step meeting after you've been in residential treatment for 30 days, that must mean that this treatment was effective, because now you want to go to a 12-step meeting. Psychiatric symptoms decreased a little bit. Again, that's not necessarily mind-boggling that after 30 days in a facility, psychiatric symptoms tamped down. These people presumably have been off of the opioids for a month. Their withdrawal has subsided, so it's not mind-boggling that their psychiatric symptoms went down a little bit. Again, a questionnaire. And then again, treatment completion. So 80% of the people completed the treatment, as if that really has anything to do with the effectiveness of the treatment. It's sort of like saying, measuring the effectiveness of antibiotics by measuring how many people finished the whole course of antibiotics. That might be nice to know, but it doesn't matter. It has no bearing on how effective the antibiotic is at killing the bacterial infection. So you see, they're using sort of proxy measurements to determine how effective this inpatient treatment was. Nowhere on here, though, is 5 years worth of drug screens confirming abstinence over a period of 5 years. That's not on here. That would be a more scientific measurement whether or not this worked. So you see, they're kind of using these secondary measurements. Again, what is the treatment? Well, the term treatment is tossed about in literature, and especially, it's on advertised. It's for all these facilities. We have the best treatment. Come get treatment. There's no standardization. There's no what is the treatment. The term treatment, it can mean anything from medication-assisted therapy, which does have some merit, to cognitive behavioral therapy, group sessions, 12-step meetings. The word treatment's always used, and it's never really specified. Even in the studies that they're putting out there, they just continue to use this word treatment, and it's never specified what treatment, because that's important. For example, with courts, the criminal justice system will always say something like, "Your court ordered to submit to substance abuse treatment," and that'll be the court order. You don't ever really hear something more along the lines of your court order to submit to cognitive behavioral therapy geared towards substance abuse. Specific. They just love to use this word treatment. And the loose usage of the word treatment, I just think it's terrible. It's opening the door to a mess of just, unsubstantiated activities, if you will, that are being passed off as effective ways of quelling addiction or stopping addiction. It's a problem. We need to get away from using the word treatment. Now, this brings us to medication assisted therapy, which does have some evidence behind it. I won't get into the research, you can look it up, but there are definite benefits, and there is improved outcomes, including outcomes with abstinence, with regards to medication assisted therapy. However, despite the effectiveness, the treatment industry it at first wanted to downplay the role. These are the big major rehabs and facilities. They kind of sweated this because it was going to maybe potentially cut into their profit. But what they've done is, they found a way to marry the benefits of medication assisted therapy to the standard behavioral treatments, counseling, group therapy, etc. And the problem is the evidence doesn't support it. And a bigger problem is that the federal government and all of these different agencies they support this notion that somehow medication assisted therapy doesn't work unless you get counseling along with it. And let's go to the Substance Abuse and Mental Health Service Administration's very website here, and they'll talk about medication and counseling treatment. Medication assisted treatment is the use of medications with counseling and behavioral therapies to treat there it is again treat substance use disorders and prevent opioid overdose. Um, Medication assisted treatment, the word assisted is thrown in there to marry it to counseling and behavioral therapies. The use of medications in combination with counseling and behavioral therapies to provide a whole patient approach. Research shows, now this is again, please, this is the Substance Abuse Mental Health Services Administration, Department of Health and Human Services. They say it's right on their website. Research shows that a combination of medication and therapy can successfully treat these disorders, and for some people struggling with addiction, MAT can help sustain recovery. So this is the federal government, and they're saying right on here, research shows a combination of medication and therapy can successfully treat these disorders. Let's look into that. Interestingly enough, Yale University here, they did a study in 2013. This is 2013, and the website here, I'm assuming this is a current website, so this is current as of now. But the research was conducted in 2018, a randomized trial of cognitive behavioral therapy in primary care-based buprenorphine treatment. Department of Internal Medicine at Yale. And the object of the study is to determine the impact of cognitive behavioral therapy on outcomes in primary care office-based buprenorphine with naloxone treatment of opioid dependence. They did a 24-week randomized clinical trial with 141 opioid-dependent patients in a primary care clinic. Patients were randomized to physician management or just, in other words, just buprenorphine, physician management, or physician management plus cognitive behavioral therapy. So they have two groups, 24-week randomized clinical trial. They looked at physician management alone, just in other words, just giving people buprenorphine, or physician management plus cognitive behavioral therapy. The physician management, it was just brief, manual guided, and medically focused. In other words, they're just teaching them how to take the buprenorphine. The other group got cognitive behavioral therapy and was manual guided and provided for the first 12 weeks of treatment. Primary outcome measures were self-reported frequency of illicit opioid use, again, not the best, and the maximum number of consecutive weeks of abstinence as documented by urine toxicology and self-report. So better than other studies, they actually documented this by urine toxicology. So they're looking at abstinence over a shorter period of time, only 24 weeks, as documented by urine toxicology. And look at the results here. We can read the results section, but the conclusion is right down here. Among patients receiving buprenorphine in primary care for opioid dependence, the effectiveness of physician management did not differ significantly from that of physician management plus cognitive behavioral therapy. In other words, there was no difference in outcome between people just receiving buprenorphine and people receiving buprenorphine and counseling. Let's look at some of the results here. These are consecutive weeks of opioid-negative urine screens. Physician management and cognitive behavioral therapy. Interestingly, the first 12 weeks, the people doing buprenorphine alone, for the first 12 weeks, had a little bit higher negative urine samples, and then that kind of flipped around out at 12 weeks. The point is, there's no statistical significance at all. So you have the physician management only in the yellow, and physician management and cognitive behavioral therapy, i.e. counseling, i.e. extra money that you pay to go to a counselor once, twice, 3 times a week. Maybe this is intensive outpatient treatment. So we see no difference. There's no difference whatsoever. So you can just give somebody buprenorphine, and with no counseling, their outcome is largely the same. Study completion among opioid dependence patients receiving buprenorphine in primary care. Study completion was defined as not meeting criteria for a protective transfer. Again, this is not very important. It's the percentage of patients completing the treatment. But as we see, now let's go back. Substance Abuse and Mental Health Services Administration, they say right here, research shows that a combination of medication and therapy can successfully treat these disorders. Then we flip over and we look at the actual research, and it does not suggest that. In fact, it suggests the opposite. Primary care management of opioid dependence, the addition of cognitive behavioral therapy gives no extra benefit compared to standard physician management alone. So why does the federal government, U.S. Department of Health and Human Services, have this in here when it's not true? And it starts to make us really start to wonder, how much money is really made by people going to these counseling sessions and these outpatient treatment facilities and these inpatient treatment facilities? And do they have some sort of vested interest in making sure that it's believed that you need to take counseling along with medication assisted therapy, buprenorphine or methadone, and that we can't possibly just let these people have the medications. We must get them in for, again, further treatment. Well, the science again comes in and it shows that it's completely unnecessary. So, again, there is no difference in outcome between people getting counseling or not getting counseling during buprenorphine treatment. So, basically, that brings us to the $1 million question: is this treatment, is it better than doing nothing at all? Well, the actual studies show apparently it's not. Uh, no treatment has actually been shown to be any more effective than not doing anything at all. So, in fact, the National Survey on Drug Use and Health, they conducted a survey, I believe the last time was 2014, but they asked 42,000 addicts, and they surveyed that many people, which is a representative sample of the United States, statistically significant. And it shows that most people actually quit their addiction on their own. And it also tends to suggest that addiction runs a course. It's a time limiting process, whether you want to call it a disease or a behavioral disorder or simply bad behavior, if you will. It apparently tends to run a course, and 75% of all addictions simply they fizzle out, and that includes heroin. They fizzle out without any treatment at all. People tend to quit addiction on their own, and the conclusion drawn from that massive survey is that people tend to age out of addiction. And that sort of implies that treatment doesn't cure addiction. Addictions, in essence, aren't actually cured. They simply fizzle out with time. It's going to run. It's going to run a course, and that course, according to that massive survey, suggests that alcohol dependency lasts about 15 years, same as heroin dependency or heroin addiction, approximately 15 years on average. And prescription opioids, will tend to last about 5 years of active addiction. And that's about my experience in dealing with opiate addiction, and a lot of people that I know who have gone through prescription opioid addiction to oxycodone and hydrocodone. Uh, Almost universally, around the 5 year mark, a great percentage of them begin to quit on their own. It becomes too burdensome for too long of a period of time. The tolerance grows too high. It's too expensive. It's lost its luster, and people begin that painful process of quitting on their own without any actual treatment. And most people who will get off of opioids will do so without attending any inpatient rehabs, without going to 12-step meetings, and without any sort of official treatment, even medically medication assisted therapy. They will just simply stop and taper down slowly over a long period of time. It's not going to happen overnight, but it may take a year before the person finally is able to come off completely. But it's been my experience that these things, they just run a course, and there's nothing you're going to do while somebody's in the midst of that course. You're not going to say anything or do anything in talk therapy and cognitive behavioral therapy and sitting in rehab after rehab and IOP, but it doesn't. None of these things are effective because And it makes perfect sense that they're not effective because, according to the most wide-reaching survey here, it looks like it's just going to run a course, and that eventually people will time out of these things. There's nothing that can be done to stop them, but there is a whole lot that can be done to do away with all of the horrible downsides of addiction. Which brings you around to, why are we focusing so much on treatment that doesn't work, that hasn't been shown to be very effective, if effective at all? You know, addiction runs a course, so why not try to reduce the harm while this is happening? Let's stop trying to cure what appears to be a natural behavioral process, and that apparently follows that natural course to an ending. It's similar to the flu. We don't try to treat the flu to cure it. We just support people while they have the flu because we recognize that it's uncurable, and we seek to minimize casualties and fatalities while people have the flu, and that's maybe what we should be doing with addiction. Let's stop trying to treat the untreatable. Deaths from addiction could be dropped to minuscule levels, with simple common sense approaches. People are dying, and I'm going to get into this in future videos, the deceptive nature of the statistics. People die from fentanyl, or they die from mixing opioids with various other compounds like benzodiazepines and alcohol. It's not at all very common for someone to simply overdose on a prescription opioid alone. Um, you know, Financial damage of addiction too is another thing that, what we have is that people are running this natural course of their addiction, but all of these horrible things can happen to them during that. And we could stop a lot of that. People are financially destroyed by their addiction, their families fall apart. They may die of an overdose. They may overdose and end up in the hospital. They may damage their brain. They may do. We can look at and focus on fixing those things. Let's decriminalize these drugs. Let's let the free market drive down prices so that people aren't spending exorbitant amounts of money to sustain their addiction, and they're not stealing, they're not taking from family members, they're not destroying their households and ruining their financial future. Let's help them get through this. Let's help them get through their addiction instead of trying to stop them and trying to cure it with expensive treatments that's making everybody rich and bankrupting the addict. Let's help them get through their addiction. Let's help it run its natural course and minimize the damage that they do to themselves and others while this sort of thing is happening. So I'm going to make future videos, but I hope I'm at least starting to make the argument that this idea of addiction treatment, it needs to stop. Let's stop bankrupting a vulnerable class of people. Let's start supporting the addict as the addiction runs its course. Let's stop financial exploitation, because that's all these inpatient rehabs are. That's all a lot of these IOPs and they're just expensive exploitation. There's nothing to suggest that they're effective. There's nothing to suggest that they truly work. The people who stop their addiction after going into inpatient rehab or through the process of IOP, they are actually simply the people that are timing out of their addiction anyway. And it's just coincidental that at this point in time they went to a rehab, or at this point in time they went to IOP or 12-step meetings. It's just coincidental that they were probably timing out of their addiction at the same time. So they may, have confirmation bias that that's what helped them. But the scientific studies show that there's no proof that any of those methods are effective. And, so, I'm going to make more videos about this coming up because it's a great subject to talk about. I'm going to go into what you can do if you are suffering from opiate addiction. I have some great ideas for helping people. In future videos, we'll address, addiction, harm reduction, withdrawal. I'm a biochemist. That's where my degree is in. And I'm going to talk about the biochemistry of tolerance and much more things along those lines, and what you can do to get if you're at the point where you're timing out of your addiction. And I'm going to go into what you can do to minimize the symptoms of withdrawal, and different things you can do to help get you through that process, and put it behind you, because that's eventually what you will do. You'll die, or you'll put it behind you. And in between those 2 points, hopefully the one never happens, and hopefully you don't destroy yourself financially and lose or ruin your family while you're going through this. I'm gonna focus on things you can do to get through it and keep your health, keep your sanity, and keep your money. And hopefully politically, we will start to make progress and get away from this silly, stupid idea that addiction is a disease that needs to be treated, and get onto a better, more validated plane of thinking that addiction is a natural behavioral deficiency, if you will, that's going to run a natural course. And, everything in due time, as they say. So keep an eye out for future videos. I'm going to get deep into the biochemistry of tolerance and all those things. All right. Thank you. Hope you enjoyed the video, and leave any comments below. Take care.